Well, good morning, everyone. Welcome to our Tuesday morning Grand Rounds. It's my pleasure this morning to introduce our speaker, Dr. Karen Yeager. Dr. Yeager is originally from Houston, Texas. After she completed medical school at the University of North Texas in Fort Worth, she moved to Phoenix to complete residency and fellowship training here at Phoenix Children's. And then after fellowship, she completed an MS degree and board certification in clinical informatics in June of 2022. Dr. Yeager is passionate about bedside medical education and loves teaching residents and fellows, as well as leveraging data analytics solutions to improve patient care and workflows. As such, she joined the fellowship leadership in April of 2023 as an associate program director and the clinical informatics team in October of 2023. Outside of work, Dr. Yeager loves to bake, travel, and do it-yourself crafts, and she spends most of her time with her husband, daughter, and 2 labradoodles. So without any further ado, Dr. Yeager, podium's yours.
All right, guys, thanks for having me. And thank you to everyone on Zoom land for joining this early in the morning. So today we're gonna be talking about opioid use disorder in adolescents. Here's a little bit about me. Since the last time I gave Grand Rounds, I had a whole nother baby, and now I'm a mom of 2 under 2. And time flies. So these are some of the topics that we're going to be covering today. And as you can see, there's a lot of ground to cover. But my goal with this talk is not for everyone to go on to be ready to initiate medication-assisted therapy for opioid use disorders. I know that most of us in our various practice settings are not going to do that. But rather, I want to impress upon you how we got to this point in the opioid crisis, and how we as providers, regardless of where we're practicing, inpatient, outpatient, or in surgical settings even, how we have a role to play in mitigating the risk of adolescents developing opioid use disorders, how we can screen them, and being familiar with treatment options so you know what's out there. And then we'll close with some information about naloxone. The background we're going to look at, we're just going to be taking a bird's eye view of the history of the opioid epidemic and a more focused lens on the Arizona data. So this graphic just starts at 1990s, as you can see. So that does not cover like the early opium dens of the 1800s or like the whole history. But just for your knowledge, 1874 is when heroin was first synthesized for morphine in England. And then after addiction reports were received, it was made illegal in 1924 in the US. And then the second heroin surge that we're probably more familiar with is in the 1970s. But a few things, this is like sort of a bird's eye view of the modern opioid epidemic. In the 1990s to 2010, a couple of important things happened. That was when prescription opioids predominated. A few factors that contributed to that. There was a marketing surge for OxyContin, which was the predecessor of oxycodone. And then the Joint Commission mandated pain as the 5th vital sign. Some of y'all younger residents may not remember this, but that was one of the metrics that hospitals participating with the Joint Commission were judged on. And that led to these factors combined led to a surge in prescription sales, quadrupled, led to over 17,000 deaths by opioid overdose by 2010. After that, heroin made a resurgence, and then they reformulated OxyContin, and then overdose deaths tripled. 2013 to 2019 is kind of like the beginning of the fentanyl era, and that is really like the modern opioid epidemic, where we have not only illicit oxycodone pills, but illicit fentanyl, and that flooding the market. By 2016, we had over 20,000 deaths from opioids. Then fentanyl analogs like carfentanil and other analogs dominated the market in 2020 and onwards, and this has contributed to a huge surge leading to over 100,000 annual deaths since 2020, and this has been maintained year over year since. And we'll talk about some of the reasons for that. This is just a little bit more detail. I just wanted you to have it for reference. Note, like in 1980, there was an opinion letter that there was less than a 1% addiction risk associated with opioids. And that was cited as like evidence-based medicine back then. I mentioned the Purdue marketing. The Department of Health and Human Services declared a national emergency in 2017, and that's led to a lot of legislation that's helped combat this epidemic. But unfortunately, we're fighting against a lot of significant floods in the market for synthetic opioids, which counteracts what we're doing. So here's a few additional statistics. Overdoses we know are a leading injury-related cause of death. In 2022, over 100,000 people died from drug overdoses in the US. That's over 300, almost 300 cases a day. Nearly 76 involve an opioid. Research shows that people who have at least one overdose are more likely to have another. And this last one, 2022, there was a huge paucity in the estimated amount of people who needed substance use disorder treatment and who received it. 13 million people received a substance disorder treatment against almost 55 million who needed it. And there's a lot of factors for that, but again, limited access to treatment, limited residential treatment facilities. A lot of these disproportionately affect adolescents as well. This visual shows the relative potency of fentanyl and its analogs compared to morphine. So you can see fentanyl is 50 to 100 times more potent, and carfentanil is 10,000 times more potent. I did a panel last year with DEA agents and federal prosecutors on the opioid epidemic and its effects on adolescents. And they mentioned that most of the opioids coming in from the Mexican and Chinese markets now are coming as straight powders. And there's a lot of advantages to this because, as you can see, these analogs are so potent. It's much more compact. So when you read about these, like DEA seizes $500 million of street value fentanyl, and you're thinking it's like a semi-truck, it's like, not that much. It's the amount that you can fit into the back of a minivan or something, you know? So that is the benefit of having these IMFs or illegally manufactured fentanyls. They come very compact. They're distributed to the streets. Then that leads to the prevalence of these like illegal pill press operations. And that's how you get fake M30, like fake oxycodones, which are M30s, Skittles, and Skittles are multicolored pill packs. So you can see the intentional marketing targeting adolescents and young people. So all that to say, that some of these choices that have led to the current state of the opioid epidemic were very intentional. And interestingly, current market now, 70% of the pills that are seized or drugs that are seized have a lethal dose of fentanyl, and the street value is about $150 per pill. So it's actually now cheaper for people to get fentanyls and fake oxycodones off the street than to like spend time in an ER trying to get like us to give them something. So what people will often do is they'll panhandle, get enough money to buy like 5 pill, their daily allotment for their oxycodone or their fentanyl, use part of that, sell the rest to get the money for their next day. And so this cycle perpetuates with a lot of despair. So a sample database from 2014 to 2017, looking at national ED data, reported that an average of almost 60,000 opioid-related pediatric ED visits were documented nationally. And the majority of these involve teens and young infants. And that makes sense, right? Like the teens risk-taking behavior, intentional or accidental exposures, and then exploratory ingestions in young children. In 2016, pediatric deaths related to opioids increased by 268%. 12% of all these deaths were in children and young adults aged 15 to 24 years old. Switching gear a little bit to Arizona-specific data, this is from ACDHS, and they compile data from a lot of EMS agencies and ED and inpatient contacts. So in 2024 alone, 12% of ED and inpatient visits for suspected drug overdoses were reported in patients under the age of 17. And this is equivalent to almost 2,500 cases of suspected pediatric overdoses. Looking at verified non-fatal overdoses, you can see on the left there, that dark red area is Maricopa County. So this is the largest concentration of confirmed opioid overdose events. It's spread throughout the state, but since Phoenix Children's is located in the center of this, we have an opportunity to intervene and be present on addressing this. I wanted to show you kind of year over year what these numbers look like for pediatric population compared to adults. So the blue line for each graphic, or the blue bar, is children age 0 to 17, and the yellow bar is like the peak incidence age 24 to 35. On the left is verified non-fatal opioid overdoses from 2019 to 2025. And on the right is ED and inpatient visits for suspected overdoses. So you can see there's it's about like 3 times more on the right of cases of suspected overdose and evaluations, and that makes sense with like exploratory ingestions and things like that. This graphic shows year-over-year confirmed opioid overdose fatalities. The blue line on the bottom is again that 0 to 17 age group, and then the yellow line, it's kind of hard to see if you want it. So here, this yellow line is 18 to 24-year-olds. So that's the next age group, young adults. So this is, I want you to think of this as a continuum and how we have an opportunity to intervene early. A few things, like you see this little dip here. A couple of things happened in, this is 2022. Number one, the CDC released their clinical practice guideline for opioid prescribing in 2022. This is looking at specifically Arizona data. And another significant piece of legislation and policy that happened in 2022 is AZDHS rolled out their Naloxone leave behind program. So understanding orders, any participating EMS agency, if they respond to a call for any reason, it does not have to be drug related. If they see drug paraphernalia or any evidence of drug paraphernalia, they can leave behind a naloxone kit at the site for the family free of cost, and that's subsidized to the AZDHS. So what does all of this amount to? It shows how there is a critical period for intervention in adolescence. There's a combination of developmentally normal boundary testing and risk-taking combined with incompletely developed executive functioning that makes adolescents particularly prone to high-risk behaviors. And this gives us a mandate to, as pediatric providers, to do what we can to limit deadly or life-threatening exposures as much as possible. A survey, like self-reported adolescents survey in 2019, showed that adolescents prescribed opioids by a medical professional, there was a 33% increased risk of continuing opioid use throughout adulthood and an increased risk for polysubstance use. So this is adolescents self-reporting this. And then pediatric providers play a critical role in prevention, screening, and treatment. I'm sorry, this slides are skipping ahead. It's on timer, so I'm just going back. Sorry if it's a little spastic. All right, so let's go through understanding the opioid use epidemic and what we can do. Here's a question. 15-year-old athlete with a mild sprain requests stronger pain medication. What is the most appropriate preventive approach to reducing opioid misuse? And these are options, and they'll come back up again with the slide-up questions. So I just wanted you to take a look at that. If I want to go ahead, okay, there we go. Now you can see the option. Oh, sorry. It just skips ahead like before, but see if I can go that way. Yeah, I go that way. Some responses. Okay. Let's see how people have responded. Good. So the correct answer is B. Non-opioid regimens are first line, and this is true for an outpatient ambulatory ED urgent care settings. This is obviously a very common complaint for athletes and active teenagers. Let's take a look at a mechanism of action. So opioids act both presynaptically and postsynaptically to produce the analgesia. Presynaptically, they block calcium channels on nociceptor afferent nerves to inhibit neurotransmitter release that contributes to that perception of pain. Postsynaptically, they open potassium channels, which hyperpolarize cell membranes and increase the action potential to generate nociception. There's mu, kappa, delta, these multiple different types of opioid receptors that mediate analgesia both spinally and supraspinally. And that's like the pain effect. But this graphic on the left shows you why fentanyl can be particular, and all opioids, but fentanyl particularly can be extremely addictive. The dopamine reward system gets activated by fentanyl, and because of its fast onset, you get this like rush of euphoric activity, and that's also one of the things that like it causes this like tolerance. So you get excessive stimulation on the dopamine reward system when you're on opioids, and for a prolonged period of time, and then you need more drug and more frequently to maintain that same euphoric effect. So causes and risk factors for adolescent opioid use disorder. One thing that I think is really interesting, that it's not that teenagers are often going to the streets as like their first exposure for opioids. In fact, that's probably relatively uncommon. That may progress later on, but there's prescription use and there's prescription misuse. There's giving away and trading. And then that can progress to illicit use. So one kid has ADHD with appropriately prescribed stimulants. Another kid has a operative procedure, ACL tear, that gets appropriately prescribed opioids, and then they swap back and forth with their leftover pills. So, and that it can be a common behavior. So that's something that we as providers need to be aware of. Other sources in the house, grandma's oxycodones for her hip replacement, or all of these other exposures. There's actually adult literature emerging about incidents of household contacts with opioid-related adverse events, and using that as like a measure to like pre-screen or contract with adult patients when they're prescribing opioids, because it can be used negatively by other household contacts. Adolescents are also at risk for substance use in general and opioid use disorder for a variety of other reasons, things that we're familiar with. We all have seen the detrimental effects of like social media on mental health and the mental health crisis as it specifically affects young people in this country. Social determinants of health also play a role in this in terms of access to care, access to mental health resources, and access, unfortunately, to drugs. They tend to have a shorter prescription history. And there's this idea of optimism bias, which once I describe it, I'm sure all of you will have also felt the same way at some point in your life, and may still, but it's very prevalent in the adolescent like zeitgeist. There's this tendency to overestimate positive effects and underestimate any adverse events correlated with your actions. So whether it's like being convinced that you're going to be the next TikTok viral sensation, or you're going to do this extremely risky thing with a pill that you got off the street, but nothing bad is going to happen because that happens to other people, is this idea of optimism bias. There's also a lot of literature to suggest that the age of onset of regular opioid use is a very strong epidemiologic factor associated with ongoing and lifetime risk of opioid use disorder. So the earlier onset that they're using opioids for abuse, and the greater their lifetime risk is of not just opioid use disorder, but also polysubstance use. And the age of onset for patients who go on to have specific opioid use disorders is actually younger than patients who are currently struggling with like other drugs of abuse, like alcohol. So age of onset for opioids is around 11.7 versus 12.6 with marijuana and alcohol. So we talked about like their impact, the optimistic bias we discussed, and then the prevalence of illicit fentanyls and counterfeits just makes the whole problem significantly harder, because you can appreciate, even if they start by doing pill swapping from prescription sources, then taking that to the street because things are coming as powders from one neighborhood to the next, you could be getting vastly different concentrations of fentanyl and fentanyl analogs. So they have no idea what they're getting when they're even seeking opioid itself. The other part of this is that often they're not seeking opioids. So getting Molly or ecstasy or ketamine, these other drugs of abuse, because fentanyl has that high like euphoric effect, fast onset, highly addictive, that's beneficial for drug dealers, because then you keep coming back for more of their products. So they'll often cut other drugs of abuse with fentanyl. So then these kids have no idea what they're even getting. So that poses a unique challenge for us. And just a reminder that the age of initiation is an important risk factor. So as we looked at those graphs, comparing the different age groups, while the adolescent group still at this time looks relatively low, those adolescents go on to be those 24 to 35-year-olds that have very high incidence of morbidity and mortality related to opioid use. Let's look at some social, mental, and physical impacts. There's higher risk for adolescents in foster care or housing insecurity. That makes sense. There's a high rate of like runaway behavior, living on the streets, and then being exposed to things that are on the streets. However, there's emerging literature that the opioid epidemic in general does not play by the same rules as other drugs of abuse. So there's also a significant exposures in suburban white male adolescents. And this can be starting as, just routine, like orthopedic or injury-related, trauma-related incidents that then progress to other things. So we just have to be really careful about not only screening appropriately, checking our biases, and also frequent follow-ups. All of these things can be exacerbated by depression, anxiety, and access to mental health. And as consequences of opioid use disorders, homelessness and financial impacts can be significant. Home access, long-term health access, along with any kind of drug of abuse, you can have medical comorbidities like hepatitis and HIV. Let's do another question. I kind of want to go to the Slido and then go back to this so that it doesn't go. Let me show the question. 6-year-old girl discharged after tonsillectomy for OSA. The nurse asked about discharge analgesia. According to current guidelines, which regimen is most consistent with opioid sparing best practices? And we're going to talk about what that means as well. So while people are in the Slido, I'm going to exit out and go back to the question. Hope it doesn't. Oh, it does? Oh, shoot. Sorry. Oh, no, there's a dozen people, so that answered. Okay, I'll give it a couple more seconds. Awesome. Okay. So a lot of you, the majority of you said Tylenol alternating with ibuprofen, and that is correct. So I want to go back to the this question. So A is the correct answer, and looking at the choices, hydrocodone and acetaminophen seems very reasonable. Every 4 hours as needed for pain, but that should be reserved as a breakthrough regimen. Codeine and tramadol both are contraindicated in children under 12. Does anyone know why? Codeine, some of y'all probably never prescribed in your life, but we used to do it a lot for a cough. There's CYP altered metabolism that can be that can be undiagnosed or unaware of in young children that can cause profound respiratory depression. So those regimens are no longer recommended. So primary opioid sparing analgesic regimens, the cornerstone is going to be scheduled non-opioid medications, Tylenol, ibuprofen, things like that, with opioids as a breakthrough. So when we talk about standardizing our approach to mitigate risk and why, no matter what practice area you go into, whether you're ER, in a surgical subspecialty, outpatient, inpatient, we all have a role to play. We need to be thinking about, are opioids clinically appropriate? And the answer is not that they're never appropriate, right? I'm never going to say that if you have a part of your femur sticking out that you shouldn't go home with a prescription for oxycodone after getting that fixed. But there are some ways that we can check our biases. There's a study that looked at opioid prescriptions, and 1 in every 2,600 prescriptions was followed by an opioid related adverse event. And 71% of those were related with therapeutic use of prescribed opioids. So people are using it the way that it was prescribed and in the doses that were prescribed, and often still had an adverse event. There was also an RCT of 146 outpatient general surgery patients that compared Tylenol with codeine, compared with scheduled Tylenol and ibuprofen, that post-tonsillectomy regimen we talked about, and there was no difference in their visual analog pain scales. Actually, on postoperative day 2, the scheduled Tylenol ibuprofen group actually did better. Multiple studies cite that there's no significant outcome improvement in postoperative pain or hemorrhage with patients post-tonsillectomy with opioids. Rather, multiple studies have shown that dexamethasone and scheduled Tylenol and ibuprofen have been more efficacious. Conversely, in like other populations, so going back to our orthopedic example, using adjuncts such as local anesthesia, blocks, things like that. It's like some of these things are very big surgeries and very painful recoveries. So the answer is not never do opioids for anything, because then you have other complications related to that. Like if you have rib fractures and you're not adequately addressing pain, then you can have a secondarily developed pneumonia and things like that. So you need to address the pain, but can we figure out ways that are a little bit more standardized? So how do we standardize our approach if we think that it is clinically appropriate? Number one, optimize your opioid sparing measures, schedule Tylenol, ibuprofen, dexamethasone, or other adjuncts, early follow-up. And then risk stratification is a really big piece of this. This is an example of a clinical practice guideline from Colorado, but there's other emergent pathways for pediatric specific populations. And it includes, like, first, is that question of are opioids necessary or not? And if they are, the data supports limiting prescriptions to under 7 days or 14 or less doses. Co-screening for mental health and other comorbidities such as obesity, OSA, existing substance use. These patients should really have like patient agreements in place, or really a second look for alternative treatment regimens. Avoid long-acting preparations and co-dispensing with benzodiazepines, because that is an independent risk factor for respiratory depression. And then PDMPs, prescription drug monitoring programs. We all have access, so all the residents also have access to the PDMPs, and you can check and see and make sure you're the only prescriber. Also co-dispensing naloxone for prescriptions, and that is just a safety measure for the patient and their household contacts. So let's look at treatment options now. 17-year-old male is revived with naloxone after smoking counterfeit oxycodone pills containing fentanyl. Which of the following is the most evidence-based next step to reduce overall risk and improve outcomes? Providing naloxone kit, initiating buprenorphine treatment, and arranging for follow-up. Recommend inpatient detox or discharge of parental monitoring. I'm gonna get my water. Oh, cruising, I'm making good time. Do we want? Oh, sure. If you have a question now, we can do it now.
Have you ever talked to those patient? I just know some of the discharging, like, so much stuff. I had a patient recently.
Stuff hasn't sent so many opioids.
And, and I had a patient recently who don't know lost.
Oh, Lord. I do have, yes, and we had conversations, and I'll share some of the work that we're doing institutionally, and specifically with the ortho division. Yeah, like there's a lot of really good work happening all across the division. Ooh, a little smattering. I like it. All right. So some people said provide naloxone and refer to counseling, and others said initiate buprenorphine. So yes, and so naloxone is an important part of treatment, especially since the patient received naloxone. They absolutely should have naloxone, but this question was a little bit tricky. The patient has a high risk of a repeat overdose and should have buprenorphine initiated to help treat his underlying opioid use disorder. That being said, I know this is a pediatric facility, and I know that this is all very difficult, and I will be the first to admit I work in the ER and I don't initiate buprenorphine often. So let's talk about it. First line for anyone not used to medication-assisted therapy. Medication-assisted therapy is like the buprenorphine, methadone, all these things. So the Suboxone, that sort of stuff, something that we're very unfamiliar with as pediatric providers. So the OR line through the Banner Poison and Drug Center available 24 hours. It's staffed by nurses, pharmacists, providers who can give real-time consultation about patient care, whether it's related to medication-assisted therapy or opioid withdrawal symptoms, drug interactions, things, and you just like, where do I send them next? So this is a really good resource and probably should just be saved into your phone. So let's talk about medication-assisted therapy. The main drugs that we look at are methadone, buprenorphine, and naltrexone. There's limitations to all of them. None of them are great because this is a difficult thing to treat. Addiction in general is a very difficult thing to treat, and there's a lot of stigma associated with it. I've listed kind of like the overall how these works, mechanism of action. Methadone is a mu receptor agonist, so it's an opioid replacement, and it's given in methadone like monitored clinics. That is not like a very kid-friendly environment, so not a great option for many of our pediatric patients. And it's also not FDA approved. Buprenorphine is the only FDA approved treatment, medication-assisted treatment for the adolescent and pediatric population. It's an oral long-acting opioid for maintenance therapy. And there's like a ton of different formulations. You can get a sublingual, a sub-tablet, a film, a subcutaneous solution, a patch. It's formulated with naloxone as Suboxone, which is very, very effective because it has a lower incidence of abuse. And then naltrexone is the last one. It works by blocking the opioid effect, so it helps maintain abstinence by antagonizing the mu receptor, the mu opioid receptor. So that's available as like a monthly IM is the most common thing you'll see. The problem with naltrexone is that you have to fully detox before you can start it. Also not FDA approved. This is a very busy slide, but I wanted you to have it as reference. On the left are like major research studies that have been done on the pediatric population related to these medications. And on the right are clinical considerations. Just long story short, buprenorphine is the only one that's FDA approved at this time. And it has shown quite a bit of efficaciousness for the adolescent population. The difference between initiating in adolescents and adults is that there's really not long longitudinal studies on how like when to stop treatment, because some people do end up in methadone clinics for life, but that's like methadone, buprenorphine, all of these agents. It's not meant to be a forever life sentence, but the literature hasn't borne out how long is long enough. And so the current recommendation is for longer treatment durations. So adjuncts to medication-assisted therapy. So for the opioid use disorder, the gold standard for therapy is medication-assisted therapy to treat their underlying addiction and dependency. However, cognitive behavioral therapy, inpatient rehab at residential treatment facilities, family counseling, all of these are adjuncts. The residential treatment facilities, the kind of standard of practice there is clonidine and detox. So if anyone's done like nursery for opioid babies, that you might be familiar with that, like detox with clonidine and things like that. And even with the babies, that is kind of going by the wayside with more compassionate measures, including weaning, like a scheduled wean with the opioids, because the problem with detox, like withdrawal is very uncomfortable. Detox is detox, like you have to get everything out of their system, and there's different ways to do that, but it does nothing to address their underlying addiction and actually presents a significant risk, because if they don't maintain abstinence, then the highest period of risk for a lethal or fatal overdose is after they've come out of rehab and detox, because now they've lost all that tolerance. And if they take the same amount of fentanyl, or they just go to a different dealer and they have no idea what they're getting, they have a high risk of a fatal overdose. Challenges to treatment. So like we talked about access, like we're not sending kids to a methadone clinic. There's not a lot of good drugs that are available. So options, it's really only buprenorphine and then these residential treatment facilities. And those are not a dime a dozen either. So you can't really just like sign every kid up. So that is currently with the mental health crisis and the numbers of patients that would benefit from treatment and the available spots for residential treatment, also parental buy-in, family consent and participation, patient consent and participation or assent, associated stigmas. These all really factor into like enrollment and retention for adolescent treatment. Let's talk about some misconceptions. So we mentioned one, medication should be the last resort for adolescents with opioid use disorders because initiating medications will banish them to a lifetime of medication. And the studies just haven't shown that. Longer treatment regimens are shown to have better outcomes, and intervening early with effective treatment can change their life course by going from a state of having an opioid use disorder to not. And there's really no point in treating a dead patient. So the point is to intervene, prevent them from having a fatal overdose, get them onto a track where they can start dealing with the coping mechanisms, the underlying mental health disorders, without also having to deal with addiction. So lifetime is not stated as like a recommended treatment course, but the jury is still out on how long is long enough. The misconception too, adolescents need the most intensive level of care, medically supervised detox or rehab to address severe opioid use disorder. And that also has not been shown in the literature. Unfortunately, I think we are missing a lot of opportunities to screen and intervene earlier. We're missing opportunities to identify mental health disorders and high-risk taking behavior that predate opioid exposures and intervening at that time. So I think that there's opportunities to intervene before it gets to severe opioid use disorder, and also removing kids from their existing psychosocial support structures, removing them from environments where they're thriving to environments where they're essentially in lockdown may not also have the best effect on their mental health and their retention of treatment. There's also a lot of runaway behavior. So in the ER, we see a lot of kids who run away from their group homes and their residential treatment facilities, get picked up by the police at parks, doing the Lord's work, I'm sure. So those sort of things are there. So seeing how difficult it is to treat these cases, let's shift gear to prevention strategies. So prevention of overdose is multimodal. We already talked about kind of like the mental health screening and things like that, but opioid prescription stewardship is a big part of it. The opioid clinical practice guidelines, smart prescribing practices, and we'll talk about what we're doing at PCH in that avenue. Also prescription storage and disposal, to Jenny's point, Dr. Hall's point about losing medications, like what do you do when you have leftover medications? And then naloxone distribution as its that last pillar of like what happens in the event of an overdose. Here are some resources for you. One is the Arizona Opioid Prescribing Guidelines. This was published in 2018. The CDC, the big one from the CDC is 2022. The AP also put one out in 2024 for pediatric specific. Guiding principles for opioids prescription stewardship includes early use of non-opioid treatments, minimum necessary duration of treatment, and frequent reassessments. There's a lot of resources for clinicians. Part of us having DEA licenses as prescribers for scheduled substances, it requires that we maintain opioid CME. So you can get that from CDC, AMA, and JAMIA. So those options are available. The Phoenix Children's Injury Prevention Team is doing a lot of really good work. They have community events all throughout the year. And even if they consult on patients for overdose events, they will provide the family with medication storage lockboxes. So that's one option to address the issue that we noted of families losing pills or patients losing pills. Medication safe storage is a big part of this. And then also how to get rid of, so injury prevention also does how to get rid of leftover pills. Our retail pharmacy does have a drug disposal site. And then I'll talk about some other community ones. The pain clinic is also a really good resource in our patient population. So when you have gotten to, like, you had your musculoskeletal complaint that you treated in clinic with opioid sparing analgesic measures, and then that didn't work, and you did a short-term opioid prescription, and then that didn't work, and now we're doing like patient agreements and things like that. What's the next step? The pain clinic has non-opioid medications. They also do pain agreements. They do pain psych, cognitive behavioral therapy, hypnosis, acupuncture, a lot of other resources to help co-manage these patients that have failed traditional therapies. We're also working on an enterprise-wide opioid stewardship program to standardize clinical practice across divisions. So Dr. Hall mentioning like the ortho division has certain practice guidelines for their postoperative patients. So does ENT and general surgery, and every service line has different procedures, and those will have to be managed in different ways. And as we said, some of those do warrant opioid prescriptions, but taking a critical eye of like, where can we kind of trim some of the fat? Can we do a better job of pre-screening? Can we do a better job of naloxone co-dispensing? And can we standardize our approach for optimizing those opioid-sparing non-opioid analgesic measures? We talked about early intervention. There's lots of options. The CRAFT screening is evidence-based screening specifically for substance use disorders. It's validated in 12 and over. General mental health screenings, the PSQ-9, GAD-7, Columbia screening, these sort of things are options for general mental health screening. The QR code is for an example patient agreement. So if you are an ambulatory provider that is now starting to do short-term opioids and you want to, like have, this is our clinic's policy on, we're going to do this much and then reassess, or we're going to have this plan in place when there's like seeking multiple prescriptions and things like that. The QR code listed here is for the Arizona prescription drug monitoring program. And then we also have links to that in our prescription writer. There's multiple pharmacy policies for safe med disposal. So if you go to like Walgreens and CVS, like they have sites listed for where you can drop off excess prescriptions that you can reference your patients to. Looking at naloxone, I'm sure most of us are familiar with what the signs of overdose are: constricted pupils, somnolence, shallow breathing or absent breathing, signs of cyanosis. Let's talk about, I think this is the final question. A 16-year-old discharged after naloxone reversal needs a discharge plan. What's the most evidence-based intervention? Psych follow-up in 1 month, education materials only, providing a naloxone take-home kit, or pain clinic referral. This is the one that was like happy. This is the one that kept skipping over. We're gonna just talk about this one because it like totally skipped over. So who thinks psych follow-up in a month is adequate discharge planning for a patient receiving naloxone reversal in the ER? Raise your hand if education materials alone are going to suffice. Raise your hand if you think providing a take-home naloxone kit is a good idea. And then pain clinic referral, this question stem actually doesn't say why the patient had a need for a naloxone reversal, so it doesn't actually point to her having a specific pain complaint. So the answer is C, naloxone. Oh, so like, so spazzy, sorry about that. So yeah, take home naloxone and linkage to medication assisted treatment is what we talked about. So let's talk about, this is just a brief graphic on how to use naloxone if anyone is in a situation where they need to. And as I tell the rotators that come to the ED, a lot of the residents in the room, you may find yourself in a situation where you are living your life and minding your business outside of Phoenix Children's where this may need to be utilized. So just so you know, it's like this intranasal spray is 2 milligrams and you kind of administer it similar to Flonase. You can also do an auto-injectable IM preparation like similar to an EpiPen. Both are fine, but the naloxone spray is pretty user-friendly. The caution for naloxone is the 2 milligrams is a full reversal. So if you look at adult practices and adult ERs and adult literature, sometimes in the ER setting, a controlled setting, they don't do a full reversal. The goal is to have a return of normal cardiopulmonary status. So if a patient is not breathing, you reverse them. But if you have like respiratory depression and you know a patient with known substance use or opioid use disorder, a full reversal will precipitate withdrawal in a lot of cases. So to avoid that discomfort, sometimes adult literature will do a partial reversal. But for our intents and purposes, we have a larger proportion of patients who have a first-time accidental overdose and a smaller population of patients with established opioid use disorder. So if you are, and especially in that exploratory ingestion group, so full reversal, get return of cardiopulmonary status, and then on the back end, the withdrawal symptoms can be managed, but just know to look out for that. On the other end of that, if you have a profound overdose, so we can see that in some of our exploratory ingestions in the infant and toddler group, they're taking huge doses of household contact opioids on accident, and you give a dose of naloxone and it doesn't work, or you do another dose that works for a little bit and then they're depressed again. Those patients may need a drip. So it doesn't mean that the naloxone didn't reverse. It's just that they've had such a profound overdose that they need more treatment. So looking at standing orders, Arizona does have a standing order to authorize licensed pharmacists to dispense naloxone without a prescription, and that's the naloxone spray is most common. We already talked about the leave behind program, so if anybody has any questions about that, I can tell you a little bit more about that, but that also allows our EMS agencies to give naloxone at the point of access when they respond to calls. There's some other sites. These are some locations where naloxone is also available for free. Sonoran Prevention Works, St. Vincent de Paul, Veterans Affairs. Some of these have like vending machines. And then our naloxone distribution. So since going live in February of 2024, we've dispensed over 500 kits to the community through the ED inpatient and a couple of surgical service lines, including ortho is actually one of the pilot groups. This was supported by an access supplemental pay program that actually subsidized the maintenance of the program and the cost of the kits, but that was discontinued on the state level for 2026. However, our leadership has been great in supporting this effort and understanding that it's a vital asset to the community. So big shout out to Dr. Bullock and the leadership. We're able to continue the program with an updated model, so we'll still be able to provide kits to our most vulnerable patients at the point of access, and we'll expand the co-dispensing with prescriptions as of naloxone prescriptions with opioid prescriptions. Additional shout out this program was actually presented at AAP in 2025 and received, or 2024, and received first place in the QI section. So shout out to Julia DeSales Zorneman for that one. So we're representing ourselves nationally on our work on opioid stewardship. So that's pretty much it. So I'll definitely take questions shortly, but I wanted to just leave you with a few takeaways. Opioid use is rising among adolescents and young adults, and those adolescents become young adults that are incredibly high risk for adverse events. So focus on prevention and stigma reduction, screen. CHCs, ambulatory settings, community stakeholders, all key to prevention management. I wanted to leave you with the OR line number for your reference. And then here are some ways that we can be involved to move the policy needle and engage with the local community. 5 is the number of fatal overdoses in the state of Arizona today. So I'll leave you with that as a call to action to see if we can kind of help prevent this on our, in our practice areas. So I'll take questions. We've got about 10 minutes. Oh, Jenny.
So you cited earlier about how adolescents are prescribed abuse. Is that prescriptions like outpatient, or does that count to inpatient use as well?
Great question. So that study and other studies specifically note like the higher risks are not single one-time or short-term opioids. The risk significantly increases when you get prescriptions over 7 days in duration, particularly 14 days. So that's why it talks about like limiting. Can you go to like 3 days is a great starting number and very common in pediatrics. But when you start going over a week of prescription PRNs and then thinking about how many doses total that is, that increases your risk of developing tolerance. So if you have like an appy and you're getting like perioperative morphine and then you get a couple of doses post-op and then you go home on scheduled Tylenol and ibuprofen, there's no suggestion that that has significantly led to the development of opioid use disorder. But if you then go home with a week of oxycodone and you're taking it regularly and then your pain's not resolved, so then you go back for another set, and then that's kind of how it creeps up. Yeah, great question. Any other?
One in the chat here. In the ED, how often are we seeing opioid overdose?
I don't have specific numbers. I know personally I have treated several, and so have my colleagues. We're actually working on an IRB right now to look at both a cohort of ED patients with opioid exposures, as well as looking at their pre-hospital contacts, either through ACDHS or Banner Poison Center, to see like tracing the patients across the pre-hospital and post-hospital continuum. So that's in the works now. Yeah. Unfortunately, we've had a lot of profound overdoses in both adolescents and and infant and toddler patients, but we've also had a lot of good outcomes with reversal with naloxone. Any other questions? Yes.
Outpatient standpoint, I don't know if I missed it, but if we have like a positive head strain on a patient, are there ways to make sure that our teenage patients don't have to disclose this to parents?
Yes. So, and your ambulatory provider, Dr. Hartley probably can speak to this, but there is a confidential note that you can document that information in.
The medication, like buprenorphine, like those
treatment. Yes. So actually in the state, it's very state by state, but in Arizona specifically, you can assent into, as a minor for drug and alcohol treatment at 12 years and older. So parents do not have to give consent for treatment of a patient who independently seeks drug and alcohol treatment. So if they're 14, you do not need parental consent if they are seeking treatment. Yeah, great.
Then where would, if we were in clinic and I would guess, I don't know if Dr. Salmon is there, I would guess that none of us have ever prescribed it. Do you know of any resources if a general pediatrician out there that's never done it in his life or her life would want to help an adolescent, get on buprenorphine? Are there any resources that we could send them to?
Yes. So the Ourline is actually really great for that. So that is through our Banner toxicology group, and they will act as like consultants, similar to how we call them for like a kid swallowed a Tide Pod or got into mom's propranolol. So you can consult them to help with initiation of medication-assisted therapy and referrals. So because we know that we already in the ambulatory setting, you have so many things that you're already doing, and these patients require close follow-up, and you want somebody who's going to be comfortable doing it. So that is a great first resource if you're not comfortable. And then also the X waiver. So some of the recent legislation through the MAT Act and the NATE Act, these are two different pieces of legislation that kind of collectively mean that all of us can prescribe buprenorphine, depending on like our comfort level, but also that we all need to maintain our opioid CME. Like those are the legislation pieces behind it. But I know that it can be something that people are not super comfortable with. So it's worth calling the Ourline first to see like, should I initiate? If I initiate now while I have them in clinic, can you follow up with them? And then, or where do I send them? Other resources within PCH, our mental health therapy group is really great about not only screening, but doing like, they have a bridge clinic for patients who need like more urgent mental health support, and that can also funnel into like helping address the various comorbidities, including substance use disorder. Great question.
Another question from a general pediatrician. In the case of younger than 12-year-olds, I think she meant to say do need parental permission. Is there any paperwork or agency that needs to be included?
In those situations, I would recommend having DCS also involved, because, and not necessarily as like a remove the patient, but if there's any barriers, if the family is like super on board and like willing, the great, but also those cases tend to have so many other complexities that I think it's worth having a call with our child protective team and DCS to make sure that the appropriate treatment is delivered with, because as we said, low retention rates, partially because of lack of family engagement, because they're getting these exposures from often household contexts. And there's a question over here.
You know what the follow-up like intervals look like for when you prescribe?
during initiation, it's more frequent, but maintenance is monthly. Yeah. And I have also seen exploratory ingestions of pediatric patients of parental buprenorphine, which is a very long OBS period. But in the case of Suboxone, less chance of an overdose. All right.
One announcement for there are some people for some reason that tuned into Teams this morning. We have no idea why that got on the calendar, but we have no intention of moving grand rounds from Zoom to Teams anytime in the foreseeable future. So ignore anything that comes on Teams. And then one more to the
So CME.